The patient is secured in a lateral decupitous position as far forward on the operating table as possible, preferably using a device such as a pegboard with radiolucent pegs to permit a good quality intra-op X-ray. The greater trochanter is palpated and outlined with a marking pen. The incision template is then aligned to mark the incision location. The incision is placed at the posterior corner of the tip of the greater trochanter, overlapping the tip by approximately 1 centimeter distally, and is oriented about 40 to 70 degrees to the long axis of the patient. The leg is positioned on a padded Mayo stand in maximal internal rotation to provide optimal access to the hip joint. The skin incision is carried down to the fascia overlying the Gluteus Maximus muscle, a length of between 2.5 and 4.5 inches, depending on patient size and surgeon experience. The fascia is then incised using electrocautery, and a Cobb elevator may be used to longitudinally separate the muscle fibers with minimal trauma. This dissection is carried out posterior and proximal to the tip of the greater trochanter and should not disturb the iliotibial band. The piriformis tendon is palpated. A Hohmann retractor is placed just above the piriformis tendon and deep to the capsular minimus muscle. The piriformis tendon is released, taking care to preserve maximum tendon length. The capsule is then visible. The capsular incision is made parallel to the obturator internus tendon in line with the femoral neck. A cut is made from the intertrochanteric line to the posterior rim of the acetabulum and is then turned proximally in a J or hockey stick-like orientation, approximately 1 centimeter along the posterior acetabular rim. The remaining short external rotators should not be released. Once the hip is dislocated, the anterior acetabular retractor is placed along the inferior neck and a standard Hohmann is placed along the superior neck. A narrow oscillating saw penetrates from the posterior neck to the anterior neck, approximately 45 degrees to the long axis of the femur. A reciprocating saw completes the cut medially and laterally. The use of the reciprocating saw protects the skin as the cut is completed from inside out. A shank screw is then used to remove the femoral head with minimal trauma. Now, the leg is lowered into maximum adduction and femoral preparation begins by removing any soft tissue over the lateral femoral neck. A calcar punch removes the lateral neck and a chisel removes the hard bone of the lateral calcar. Lateralizing reamers are passed through sleeves that protect the skin. Broaching begins with the smallest available broach. Broaching continues to the appropriate depth of insertion and size as determined by preoperative templating. The depth gauge assists in measurement. The broach is removed, and the femoral trial is then impacted. An anterior acetabular retractor is then placed along the acetabular rim just below the anterior inferior spine. It is secured just over the bony rim, and the handle is tilted toward the foot of the patient, retracting against the tip of the greater trochanter and not the gluteus medius muscle. If the retractor shifts proximally, the gluteus medius muscle may be unnecessarily traumatized. A narrow Hohmann is placed above the labrum, just inside the capsule at the 12 o'clock position, about 1 centimeter proximal to the lateral rim of the acetabulum. A small amount of dissection facilitates separation of the capsule from the labrum. This provides a shelf for placement of a Steinmann pin above the lateral rim of the acetabulum, directed proximally so as not to interfere with reaming. After placement, the pin is bent at a 90-degree angle and acts as a superior capsular retractor. A pinpoint posterior acetabular retractor is then placed posteriorly along the inferior acetabular rim and straddles the ischium. Like the superior acetabular retractor, it sits between the capsule and the labrum, preserving the capsule for later repair. The pinpoint retractor is secured using 1/8 inch pins. Soft tissue is cleared from within the acetabulum. Complete removal of the labrum is then carried out using a long bovie tip and long pituitary type of rongeur. The adapter is threaded into the central hole of the acetabular trial component. The cup portion of the portal placement guide is then placed within the acetabulum and held about 15 to 20 degrees adducted from the vertical to account for pelvic rotation that is typically present when the femur is dropped into adduction. The guide is then rotated so that the trocar will penetrate the skin just posterior to the femur. A 1 cm stab wound is then made. The trocar and cannula are then placed through the portal placement guide sleeve to create the portal access point distal to the main incision and posterior to the femur. Observe the location of the cannula through the main incision as it enters the acetabulum. Hold the cannula in place and withdraw the trocar. The portal guide is then removed. The newly designed 8 mm Reamer driver may now be used in the appropriate orientation for precise acetabular preparation without the typical limitations posed by a short skin incision. The appropriate size acetabular Reamer basket with its adapted hex socket is passed through the main incision. The 8 mm Reamer driver is passed through the cannula. Reaming continues with progress carefully assessed after each pass of the Reamer. Final preparation is generally complete after using 2 or 3 Reamer sizes. The threaded cup adapter is then screwed into the apical hole of the modular acetabular component. The acetabular component is placed on the alignment handle, passed through the main incision, and located in the desired position within the acetabulum, generally 40 degrees of abduction and 20 to 25 degrees of anteversion. The acetabular impactor shaft is then passed through the cannula. Hitting centrally will usually seat the cup in the position in which it is being held, but careful observation is required as the cup may be redirected as it encounters hard or soft bone. Control of implantation is achieved by compensating for these shifts by repositioning the impactor rod to a more peripheral location. This will reorient the cup as needed. Once the acetabular component is seated, the alignment guide is removed. Use the impactor shaft and T-hook to remove the threaded cup adapter. The acetabular liner is inserted into the acetabular shell and impacted using the appropriate sized liner impactor and the acetabular impactor shaft. Trial reduction then proceeds using the pro-femur modular necks and heads. Full extension and external rotation are tested to the point of applying pressure on the posterior border of the greater trochanter and the femoral neck of the prosthesis. The femoral head is palpated and checked for any subluxation. The hip is further flexed to 120 degrees to look for any additional impingement. Once the desired neck and head combination is chosen, trial components are removed and the femoral prosthesis is inserted, followed by the neck and head. Ensure that the modular neck and stem pocket are completely clean and dry before assembly and during impaction. Impact firmly to securely seat the neck and head with 3 firm mallet blows. The closure begins by approximating the joint capsule superiorly and inferiorly. The piriformis is reattached to the posterior edge of the gluteus medius along with any other short external rotators that have been released. The fascia over the gluteus maximus is reapproximated, followed by subcutaneous tissue and then skin. Proper surgical procedures and techniques are the responsibility of the medical professional. The guidelines are furnished for informational purposes only. Each surgeon must evaluate the appropriateness of the procedures based on his or her personal medical training and experience. Prior to use of the system, the surgeon should refer to the Instructions for Use package insert and surgical technique for additional warnings, precautions, indications, contraindications, and adverse effects. Instructions for use package inserts can be found under the link for prescribing information on Microport Orthopedics website at ortho.microport.com.